Somebody make some noise just to make sure I can hear
Well, you
you.
know that I'm here, but I don't
Okay, yeah, we
I
always,
don't technically count, but
you do count. Anybody have a question or something you'd like to discuss today? Please. You know, that's what I expected. Nobody, huh? Let me share my.
Hi, Dr. Calgill. I do have one question I could ask.
Oh, Jack, thank God.
One thing that we've been wondering about, so we have a Prismaflex that we have used to do TPE, and we're wondering about the process for blood priming it. And was wondering if you could talk about that a little bit.
Sure. Well, I'll have to stretch my memory a little bit. So the first thing about blood priming is you need to kind of make a recipe for what you're going to prime with, and that circuit's probably about 100 mils or 110 mils, something along that line, depending on whether you're using the neonatal or you're using the pediatric lines. And the recipe I usually use is something like 30 or 40 cc's of packed red blood cells. And we have a blood bank. We have our own blood bank. And so we often get a very enriched packed cell product that will be somewhere between 70 and 80% packed cells. The San Diego program that I was in, when we got packed cells from them, it was only about 60%. So a little bit, the volume that you're going to use for packed red blood cells would depend a little bit on what the hematocrit is of the product you're using. And hi, Jethro. And then I used to use head of starch as a colloid. You need some form of oncotic equivalence in that. And I've gotten so now that I pretty much, particularly if I'm going to do plasma exchange, I'll go ahead and just use plasma, and then usually about 30 mils of plasma. You could use head of starch, but I usually, if I'm going to use head of starch, then I try to keep that down to less than 10 mils per kilo. And then the rest is going to be saline. And so once you're going to initially prime the machine with saline. So it sets up with saline, and you're sitting there with a machine that's full of saline. And then there's an option on there to do a blood prime. And typically what we do is we hang our, and so you need to make up whatever your blood priming solution is, you need to make that up aseptically. But usually you can get a transfer bag or some other sterile bag, and then we just draw these things up in syringes and put them in the bag. Let's see, our pack cells for a dog would usually be about 70 to 100 mils, and so we don't use that whole bag. We usually just use, and oftentimes, particularly if you're doing plasma exchange, is this for plasma exchange or is this for dialysis?
For a plasma exchange, yeah.
Yeah. So I don't like to give, and the thing that you're most commonly doing the plasma exchange for is, put that up there.
I popped that in there just to show some of the supplies that aseptic setup there in the top right is how we prepare our blood priming.
Perfect. And you use 60 mils of packed cells. We have a really pretty robust product, and so but you could use more. But if you don't want to give that whole packed cell in your blood prime, because then you're going to expose all those cells to the antibodies. You haven't exchanged the patient yet, and so you've got all these antibodies floating around, and so we try not to get those brand new cells that you hope the patient's going to hold on to. We don't like to deliver them all. No, you didn't have to take that away, Jethro. We don't want to give all of those cells at a point when those cells are most vulnerable to getting tagged with antibody. So we just use 30-40 mils of that, and then typically what we would do is we would take the rest of that Paxil product, not the product, but the Paxil bag that you have, and give that as a replacement solution later on in the treatment. And I can show you some example. Actually, I was sort of set up today to talk about IMHA, so this fits in pretty nicely. I didn't prepare it, but I've got a bunch of slides and stuff that I can grab as we go along. And then the Prismax or the Prismaflex will have an option to do blood prime. So it's a key that you push, and typically then you would spike that bag of the priming solution. You would spike that, and then we usually draw that into the machine until we start to see red cells coming back the effluent line, the return line. And then what we would typically do is we would pause the blood prime and then double spike that bag and then continue the priming process. So now you've got about 70 or 80 mils of blood product in your bag, and then the rest of it is going to be saline. And with our Paxil unit that we get from the blood bank, usually that process will yield an hematocrit in the blood prime that's probably 26 to 28. If you want it higher than that, then you just put in more red blood cells. But then once you spike the bag, then you continue the priming process, and then that blood will recirculate in the bag and evenly distribute the blood product throughout the entire extracorporeal circuit. You could just bleed it on until you start to get cells coming back, and then stop and then hook it up to the patient and go ahead and do that. But our Optia machine, typically they have it set up so that you deliver 200 mils of blood prime. Well, we're not going to deliver 200 mils of blood prime, but if we spike the bag, our priming bag, with both the inlet line and the return line, and then you've got about 70 or 80 mils that get distributed into the circuit at the time that the cells are going to start coming back in the return line. Then you just spike the bag and just recirculate that for another 100 mils or whatever, and then that evenly distributes the blood throughout the whole extracorporeal circuit. And that's a pretty good option. Jethro, do you have any other comments about blood priming? Oh, before you say there, and then there's another option, and so you under the priming option, or under priming option, one is the blood prime, and then you can do more priming. And so if you need to do something else, you can go ahead and do it then. But there's a specific in the priming process, there's a specific key that you can push to distribute a blood prime.
Yeah, and I sometimes do just do the manual prime and do the same thing. But one of the things I found, my circuit, the first time I did this way back, my circuit was 130 mils. I needed to make sure that this added up to a little bit more than that, because I did end up losing just with some of the connections. There's mils here and there, and a little bit because I recirculate in the bag for a cycle or two, like you said, to distribute the red cells evenly. I would catch some air in there if I didn't overcompensate for the volume of the circuit a little bit.
Yeah, typically on our machine, there'll be enough volume in that bag that it doesn't drain, it doesn't completely empty. If you pause the priming process because you'll have about 70 mils, maybe a little bit more in there. Or you could pause it right before. You want to leave about 5 or 6 or 10 mils of blood in the bag, so that you don't draw air, and then you can recirculate it. And then whatever's left in that bag, then we just usually give that as a replacement solution at the beginning of the treatment, so you don't waste any cells. But that's the way we would prime it. But there would be no reason that you couldn't use a higher percentage of packed cells and a smaller percentage of your oncotic solution.
We in this particular case here on the screen, we did the 60 mils because it was half of a total unit, and just in the interest of balancing that out, we saved. We were going to do a second treatment the following day, so we saved that half
Yeah.
unit for the blood prime the following day as well.
That's exactly what I do as well, unless I need to give the rest of that unit at the end of the treatment to boost the hematocrit a little bit. And I can show you what that does here in just a second. The important thing is that you do need some because there's no oncotic forces in the packed cells, and if you're going to give otherwise you'll give a lot of saline, and that saline will redistribute once the prime is in there out of the vascular compartment, and then these patients will get hypovolemic if you don't have some oncotic equivalents in your priming bag. And typically, if that hematocrit in the bag, and I always check the hematocrit in the bag. I usually check the hematocrit in the packed cells, and then the hematocrit in the final solution, and then in the bag that I'm going to prime with, and then I usually check the hematocrit right after I've delivered the prime. And typically it's between about 26 and 28, might go up to 30, but you're typically starting with an animal that has a hematocrit of 12. So after you prime, they're better off than they were before you started. And you don't have to necessarily get them up to some normal range. You just need to get them to a safe range.
Okay, so just to make sure I understand, you take like your sterile transfer bag, you mix your part of red cells, maybe some plasma and some saline into that.
No, you don't put any saline in the bag.
Okay.
The saline is going to come from the saline prime that's already in your circuit.
Okay.
So you just have your plasma, and you could use head of starch, but I've gotten away from using head of starch. You got your plasma and your cells. You deliver that to the machine until you start to see red cells come back the return line, because you don't want to waste those. And in the human world, they would just set up a 200 mil prime, and they deliver that 200 mils, wasting half the cells. But we don't do that because those cells cost a lot and they're very precious. So as soon as you start to see red cells come back in your return line, we pause the prime, and Jethro, maybe put your slide back up again, because I think you showed that on your machine.
Yeah, I do. Just for the sake of a little bit different, I did put a little bit of saline in my bag to make that my full prime.
So that you've got a little bit more volume in there. But then you can see on the lower left-hand corner where now that bag is double spiked, and you're drawing out of that bag and delivering back into that bag for another 150 mils or 100 mils or whatever, and that recirculates it in the machine. But typically, this bag's pretty full, but typically my bags would only have about 70-80 mils in it, and so usually, at least on the Optia, after about 65 or 70 mils, the cells are starting to come back the blue line, and there still will be 10 or 15 mils in the bag. So I usually don't put the saline in there, because you're gonna use the saline that's in the priming, that's already in the extracorporeal circuit from the initial priming.
And this is the draw into the circuits. We haven't hooked up the blue return line yet, because we're still just priming it with the blood product there. So the blue spike, as you said, would go into the second spike in the blood bag. So this is just as it's just starting to get drawn into the machine.
Yeah. So I'd give you two other tidbits here. One is, so I really like this method. You have two options. You either transfuse the patient before you do the treatment, and in our ICU, that's going to take 2 or 3 hours to do that. Or you can blood prime, and that takes you 15 minutes. So do you want to delay your treatment 2 or 3 hours, or do you want to get going with it? And again, this is something, you know, we fussed and fussed when blood priming first, when people first got brave enough to do it, because you're delivering this huge, essentially an entire transfusion, you know, in just a matter of a few minutes. And we were all a little nervous about doing this until, and I forgot who the first person was that did it. I don't, maybe it was Knob, or I don't think it was Dr. Langston, but it might have been in her program. They just decided to do it and found out, oh, we did that and there was no problem at all. And then the next brave person did it, and oh, we did it and there was no problem at all. And so then finally blood priming has become really, really, really routine. And the bottom line is we really don't see any problems. We typically, on our plasma exchanges, we usually give Benadryl, and some people don't give Benadryl. And when I've looked at the papers that have talked about doing plasma exchange, it seems like there are more incompatibility reactions from people that don't use any Benadryl as part of their treatment modality. We do on every patient, and it's really, really, really rare that we have any incompatibility product reactions in these dogs.
Although I think the veterinary paper showed that the patients that got Benadryl, there was a higher frequency of allergic reactions to them than those who didn't.
Well, that's not been my experience at all. And I'll show you one other thing in a minute where we actually we use pack cells as a replacement solution, and you can deliver a whole unit of pack cells in about 15 minutes. And we've never had a reaction. In fact, I think it's better than doing a transfusion. My own personal biases are that a lot of the transfusion reactions that you see, even the fever, certainly the vomiting, and some of these other reactions I think they're not exclusively due to incompatibilities. I think they're more related to the increases in blood volume that you get associated with that. Because when we deliver the pack cells as a replacement solution, we take out a chunk of plasma and we replace that plasma with pack cells. So two things happen. Number one, you haven't changed blood volume at all. Blood volume stays exactly the same, and you get more bang for your mils of pack cells, because the hematocrit goes higher quicker than you'll get with a transfusion. With a transfusion, you don't take out a unit of plasma, you just add those pack cells to the already existing blood volume. And that causes hypervolemia in these patients. And in my experience, that's a component of reactions that you might see, even fever. And because we never see that when we give these products as replacement solutions.
No, I think the paper was actually looking at intoxications, and they saw more reactions in patients that were receiving centrifugal TPE, and it was multi-institution, so that there were some programs that had given Benadryl, some programs that didn't, some programs that only had centrifugal, some programs that only had membrane-based TPE. So it's obviously there are inherent biases to each of the sites, but interestingly enough, it was if they had received Benadryl and if they were receiving centrifugal TPE, there was a higher frequency of allergic reaction in those patients compared to membrane-based TPE.
And what kind of reaction is that described? Is it urticaria?
Yeah, I think it was hives, pruritus. I forget all of it, but yeah, it was interesting because you would think that I think it makes sense that if you're going to see it, you might see it with centrifugal, since it could be a faster procedure, they could get exposed to the plasma faster than they would when you're doing membrane based. But yeah, they saw the opposite. And it was just retrospective. So certainly it's not hard data, but it's what's out there.
Well, mine's not hard data either, but I mean, it's hundreds of plasma exchange treatments, and we started it right from the beginning, and so you can do it or not do it. It doesn't seem to, the Benadryl per se doesn't seem to be adverse in the patient, so that's not a particular risk. The only patient I've seen a reaction to got some reddening around the eyes. I've not seen pruritus, and I've not seen urticaria with our plasma exchange treatments. And that one treatment was the one where we forgot to give the Benadryl, and then when we gave it, all those reactions went away. So I'm actually an advocate for giving Benadryl before you start your plasma exchange.
One of the hangups that, some of the literature around giving the Benadryl, or some of the studies that have included that they're giving it intravenously, which the critical care world has been a huge, concern for reaction to that. However,
Exactly.
giving it, sub-Q or IM right as you're about to heparinize or anticoagulated patient also leads to a risk of some kind of hematoma formation too. So it's a little bit of a trade-off there.
Well, we always give it sub-Q, usually about 15 minutes before we start the procedure, if we can remember to give it, in that time frame. And we deliver it with a 25 gauge needle, and we've never had any bleeding. Most of our plasma exchanges have been with regional citrate, admittedly, although if it's an IMHA, those patients would usually, they'd be on all kinds of other antiplatelet drugs and Plavix and other things, maybe enoxaparin, and we usually do give heparin to those patients, except the patient that I'll talk to you about here that was bleeding. So we didn't give any heparin to this dog, but we've never seen bleeding at the injection site. And again, you just made a big incision and put your gigantic hemodialysis catheter in, and you often don't see bleeding around that either. Not that I'm suggesting that you can't get bleeding. I've got a very nice example of a dog where we gave the Aranesp after the treatment, kind of immediate. And this is one of the Cowgill's things. I'll give it. We usually would wait and give the Aranesp later, but the dog was going home and needed it. It was a Shar-Pei, and I gave it, and that dog just about bled out from that subcutaneous. Didn't bleed, didn't hemorrhage, but it bled subcutaneously. So injections are always a risk in heparinized patients. Don't ever forget that. And in our policy, when we send them back to the wards or to the ICU, one of the things that goes on the treatment sheet is no needle sticks until 8 o'clock or whatever. So that's part of the standing orders that these patients go to the next building with.
The one other
Go ahead.
thing I'll add here real quick, I know you've got something else to talk about too, but
No, I have nothing to talk about. I have some examples that I can show you of an IMHA patient we did a week or two ago, but that's just the backup up my sleeve. So I'd rather talk about what people want to hear.
Well, I think if you can dig up that slide you have that has the using red cells as a replacement fluid and the more bang for your buck, I like that's really a nice illustration as well. I was going to say, just with the blood prime here, we were blood priming this TPE 2000 circuit because our patient, this was 30% of their blood volume. The other consideration with this, and we were, heprinizing, not using regional citrate anticoagulation, but the citrate load that they will get in that rapid transfusion here from the combination of FFP or FP and packed red cells can be quite significant in these small guys as well. So I'm always cautious to be ahead of the curve on getting some calcium gluconate going for these guys if I'm going to blood prime too.
That's a good point, Jethro, because on the Optia, if you tell it that you've done a blood prime, it knows it knows what the citrate is. And again, we've diluted, so you usually have 15% citrate in your blood product. And we've diluted that down probably about 30, 40%. So I usually tell the machine that it's not 15% citrate, it's 6 or 7% or something like that. But the Prismax doesn't tell you that, and it doesn't know that. And so you have to understand that this is a product that has citrate in it, and you need to deliver that appropriately. Otherwise, you could run into some problems of delivering too much citrate. That's a good point. On the Optia, it's not a deal because it won't let you go fast enough to do that. But on the Prismax, you could turn that thing up as fast as you want and deliver that pretty quickly. I'll show one slide here, Jethro, if you stop sharing yours. I'd have to dig to find that other one that I was going to show you, but I'll show this one. It's not my best example, but it was the one. Oops. Stop sharing. Oops. I want to share. It was the crit line from this dog that I could talk about. Here's this is hematocrit going along here. This is during the treatment. One of the things that this dog came in with an hematocrit. This isn't the start of the treatment. This was this crit line had to get restarted, and so the dog came in, had just gotten a transfusion fairly recently. And I don't remember, it was 2 or 3 weeks ago. I don't remember all the details, but he came to the VMTH. He'd already had 4 or 5 transfusions, I think, at Elsewhere Animal Hospital. It came in with a hematocrit of 8, got 2 transfusions in Davis. And so before we started, when we were putting the catheter in, his hematocrit was about 20. But their hematocrits always drop when they get anesthetized. And by the time you get them on the machine, they've usually dropped some more. And then when you give them the prime, it's going to drop some more. And then if you start off with saline, it's going to drop some more. And if you give any head starch as your oncotic replacement solution, it's going to drop some more. And so the crit line was doing something funky, had to get restarted. And here, the hematocrit got down to about 11 or 12%. And at that time, I would have ordinarily probably given some blood, but the dog was really stable. I didn't want to give the blood right at this part of the treatment. But we get out here, this is 1 hour, 2 hours. So 2 hours into the treatment, probably we're already done about 0.5, 0.6 plasma volumes. And I gave, and there was a little bit of drop here. And this dog was bleeding in its GI tract. It was the reason we didn't give any heparin. And you can, if you're following the crit line, you can actually see bleeding. This line will just drop over time. And I've got an example where a dog was really bleeding tremendously. We'd give a transfusion, and then you just see it just disappear. But this was the leftover, well, there was a small unit of packed cells that we had. And so you can see that we gave these cells over about 10 or 15 minutes, and it goes from an hematocrit of 10 up to, I don't know, maybe 17, 18, something here. And then we gave another unit here at the end of the treatment. This was a bigger volume. And you can deliver those cells, pretty quickly, and so you send the dog back to the wards with an hematocrit of 25 or 30. You don't want to get it too high, because if you get it too high, you'll shut off the signal for red cell production. But you want it so that it's safe enough that the dog can go back to the wards. And so this is what you see when you deliver packed cells as part of your replacement solutions. And again, I put the crit line on all these patients. It's a little bit fussier to do it on the Optia. You have to surgically manipulate the line to put the crit line in. I don't have pictures of that right here either, but I can go over that if somebody's interested in how we do that. But we take the inlet line and splice it and put the crit line in line after it's seen the citrate delivered. Otherwise, you'll get clotting in that device. But this is the benefit you get from giving those packed cells as a replacement solution. You really get a nice spike in hematocrit. And this was 1 unit of packed cells in a 20-kilo dog. So that's a pretty good response for 1 unit of cells. And again, and as Jethro said, part of the advantage is that you're not just adding volume to an already expanded extra intravascular volume, particularly if these patients already have had multiple transfusions. The blood volume stays neutral because you remove 10 mils of plasma, or you remove 70 mils of plasma, and you deliver 70 mils of plasma in that hole. So the red blood cell percentage to the plasma percentage goes up really dramatically, and you get a lot more therapeutic benefit by giving it that way than you do by giving it as a transfusion. So we've been pretty excited about one that you can give a blood prime readily without a lot of fear of consequences. And then we also, if you need to intervene very quickly, like we would here, you can intervene quickly and deliver those cells quickly and get the patient stable again. Any other questions on that? But the Prismax is all set up to do blood priming. And so just read the manual. There's an automated system on the machine that where, as part of the priming sequence, it'll ask you, do you want to do a blood prime? And then you can just push that button, and then it'll direct you how to deliver that. Yeah. So this was a dog. I'll just show a couple of highlights from this dog. This was a mixed breed. They said it was a dog that didn't look like that breed of dog at all, but it was well, maybe I got a picture of the dog here somewhere. I'll show you. Yeah, so this is a little, fairly young dog. This was I think about a 4 or 5 year old dog that just got ill. We don't really understand any of the triggers that might have precipitated this hemolytic event, but he just got ill, went to the veterinarian. The veterinarian gave him a shot of antibiotics and I think a shot of steroids. Didn't recognize that it was an IMHA at that time. I don't think he did a hematocrit. And then the dog continued to decline at home. They took it to a specialty hospital where I think the hematocrit was between 6 and 8. And so the dog was really highly agglutinating. And so they recognized it as a likely IMHA, treated it with transfusions, I think cyclosporin and pred or dexamethasone. And they had given the dog 4 or 5 transfusions before they sent it to Davis for plasma exchange. And so this is when we saw the dog, and you can see how icteric he is here. I'll just flash through a couple of there were a couple of look at how profoundly yellow that dog is. One of the other things that maybe this picture doesn't, I'll show you this first. Look at this bag. I mean, not only is it this yellowy orangey color, but this plasma was just opaque. It was like it had a bunch of particulate material in it, and you could actually see the inlet. The inlet is here to the bag, and you could actually see in this particulate stuff just swirling up into the bag. And it was so bad that the AIM system on the Optia couldn't read an interface, and so here's the connector, and I think this is after we had treated the dog. Oh no, here was the other one. Maybe this one was the first one. But look at how, so the red blood cells are down here, this little line right down here. And a lot of times you'll get an animal that's hemolyzed or is very hemolyzed, and the system that sets the interface, and I could turn this. Let me see. Let me switch this so it looks normal. Oops, I went too far. So usually you want the interface to be kind of right here in the middle of the connector. So it's, you know, half plasma, half packed cells. But this plasma was so opaque and just discolored enough that the machine couldn't recognize where the interface was. And we kept waiting. Usually the machine will establish the interface in about 5 or 6 minutes, and then it'll start plasma exchange. And we had it set up correctly, and we're waiting 10 minutes, 15 minutes, nothing's happening. And it says, you know, that it's struggling to find the interface, struggling. And it was pulling plasma off, and you can see the plasma that's coming off is, you know, clear. There are no red cells in there, which is what you would worry about if the interface was way up here, that you might be sucking red cells. And when I looked down to take this picture, you know, you really couldn't see an interface either, yet the plasma that was coming off was clear. But the machine hadn't seen the interface, hadn't established the interface, so it wasn't exchanging yet. And then what you have to do at that point is you have to disable the aim and then just run the treatment manually. And the reason that it couldn't find the interface was that the color, the discoloration, the opaqueness of this plasma. After we treated it a while, oops, and I've lost my. After we treated it a while, it got so that it looked like this, and I'll switch this around. And the red cells are way down here. They're going to come up this line. The plasma is still coming off. This looks a little redder now. I mean, it just looks red, but you can see that the plasma that's coming off is absolutely yellow. There's no hemolysis in there, and there's no red cells in there. And we didn't see any red cells in the. We spun the bag down. There were no red cells in the plasma that I showed you. And then I think we have one more a little bit later into the exchange. So now we're getting rid of all that crap, and you can see that the plasma has really cleared up. So you've got this thin layer of red cells down here at the very bottom, and then all this is plasma. And ordinarily, now we're doing this manually, so it hasn't established the AIM, which stands for Automatic Interface Management System, where usually it would make this about half cells and about half plasma. And so this was later into the treatment. So you can see that we really cleared out a bunch of really nasty, terrible stuff. The other thing that I wanted to show, because this is just really exciting. I'll go back to the beginning here. One more. So this was the dog's in-saline agglutination reaction at the start of the first treatment. And that is really nasty. This is at room temperature. So this is a warm agglutinin, probably an IgG, I would suspect. And then at the end, and this dog, we did about 1.7 plasma volumes of plasma exchange. And then we hooked the dog up to carbon for plasma absorption afterwards. And what I really wanted to do, we had a carbon that would actually remove antibodies, but I'd used that cartridge and it wasn't available. So all I had was a big echo device, and I put that on. And at that point we thought, well, we'll just remove cytokines and we'll remove whatever else might be available. But this was the in-saline agglutination reaction at 1.5 plasma volumes of treatment. I guess we did 1.5 in this dog of plasma exchange. And then we switched the dog over to plasma absorption, which is here. So now instead of running the plasma up into the waste bag, where is the waste bag? Can't even see it. Well, it's behind here. Now the plasma comes up, it goes into the carbon comes out of the carbon, goes up into this kind of intermediate bag, and we put a little bit of volume in this bag just for the same reasons that Jethro was talking about. The waste pump and the replacement pump don't pump at exactly the same rate. So you need a little bit of volume in there so that you don't run this bag dry. But this is after the plasma exchange. We're doing plasma absorption, and we're running the and we mostly did this to try to get rid of the bilirubin too. This dog came in with a bilirubin of 60, and he was in a coma. So obviously neurologic manifestations of the hyperbilirubinemia, at least that's pretty likely that was going on. We got then we wanted to get the bilirubin down, even though I didn't have the material I wanted to remove additional antibodies. We thought, well, let's put the carbon on there that will remove bilirubin to a greater extent than we have with our plasma exchange, and then potentially we could get some more benefit if it's going to have any additional cytokine removal as well. So the plasma, now the machine is just separating plasma, but instead of setting that up into a waste bag and using donor plasma as the replacement product, the dog's own plasma serves as the replacement product. So the plasma comes into your absorptive device, comes out of the absorptive device up into this kind of exchange bag. So it's coming up here. You can, this is the line that's actually going to the waste bag that's up behind all of this. So the plasma is coming up from the column up this line, and then it's being returned to the patient by this line. And so then bad plasma comes in and better plasma comes out. And then at the end of that, let me show you if I've got it here. At the end of that process, this is what the N-saline glutination reaction looked like. And I didn't expect that we would get any further improvement, but you could still see a little bit of agglutination around the edges on that other one. And this one, so in the first treatment, you've eliminated all that agglutination reaction. The dog, the dogs will usually tolerate, this dog was 3+ incompatible with all of its donor blood at the start of the treatment. And then at the end of the treatment, we gave that unit of pack cells, as I showed you before, got the hematocrit up to about 26, I think. And by the next morning, it had only dropped 3%. So it was down to 23. So this is really the benefit that you get from plasma exchange. And I'm kind of an old soapbox on this, but when an animal like this comes into your hospital, when they've already seen immunosuppressive drugs, they've already seen at least 2 transfusions, I think plasma exchange ought to be your first line therapy. You shouldn't waste any more time. And this dog came in, they didn't call me until the next day. But this dog probably should have been exchanged the first day that it came in. And we just find so much more benefit in stabilizing these patients if they get plasma, these really hard ones, these really bad ones. And this dog was horrible. I mean, this was one of the worst ones I had seen. They just do. I may be able to show you one other thing here, Jethro, that you were talking about. No, I don't have a picture of it. Just one other picture of this dog's icterus. He's really very profoundly icteric. I should have shown the picture without my finger in there. So any thoughts or suggestions or comments about that? Again, you can see what a huge benefit when you look at this plasma. I can get that bag up again. When you look at this plasma, this is nasty stuff. This is really, really nasty stuff. And whatever's in there, you're removing it with the plasma exchange. So these patients just really, really benefit from first line plasma exchange rather than waiting 3 or 4 days to see if all your other therapies are gonna stabilize the dog. my rule typically is, by the time you start in your second transfusion, you ought to be calling me. Because you're just otherwise gonna, and I think this dog collectively got 6 or 7 transfusions before, he had 4 or 5 before he got to us, and then got 1 or 2 when we got him, and then he got some more during this treatment. So it's a lot of blood that just got eaten up. And once you plasma exchange them, they get much more stabilized. That's all I got. What a boisterous crowd we have here.
In fairness, probably half this crowd are third-year veterinary students that are joining me in this adventure into learning about extracorporeal therapies.
Good. I hope we can indoctrinate them.
They may not have. We've only had a couple of sessions so far, so they may
Yeah,
not have a whole lot to say.
I was out of town yesterday and I didn't get home until really late, and I forgot to send the link to the old listserv that we have. I'll probably give that listserv to Summer, although it needs to be edited a bit. But some people don't, unless you're part of the ACVNU, you probably don't get these announcements. And so I usually try to send the link out to the old IRRR listserv, but it just was so late last night, I didn't get around to it. But we welcome the vet students. We love to have them here. Do any of them have any questions? You should name one, Jethro, and we'll pick on them to see if they have any thoughts.
Oh, I warned them this could happen, so I'm sure they're all signing off as we speak.
Who else is on here?
Um,
JD was on there. Any comments, JD?
Larry, as always, you just leave us speechless with your concise yet thorough description.
Oh, you're blowing smoke, I can tell.
No, it was excellent. I don't have much to add on what you were talking about. We messed around.
Why don't you show us your new room?
Sure. So this is our new dialysis room that we are still kind of setting up in place. Let me see if it's possible that I can switch my camera.
So I talked with Jeff yesterday. He says you've got 3.5 stations. Is that what he told me?
Yeah. Can you guys see my camera? Is it coming across? Are you guys able to see? I'm trying to use my phone as a camera. I don't know if it's working.
it's working.
Okay. All right. Thanks, Jethro. Yeah, so this is our new room. Again, we're still kind of setting everything up. We have 3 treatment bays, and we have our a big change for us was getting our RO system in a different room. So we have the RO water ported in, and we have our dialysis machines having hookups on the front of the table. That just allows them to be hooked up and disconnected a lot easier. And then
Let me just pause you there. This is an excellent idea. And I've been associated with a bunch of dialysis units, and the first one, the water and stuff came down from the ceiling, the oxygen came down from the ceiling. That was terrible. And we've gotten our new room, we wanted all of that at the end of the table, and this is a great place to have it. My other suggestion, maybe you'll get there, is you want at least 8 or 10 plugs around each one of your stations.
Right. Yeah, I told them to essentially make wallpaper with outlets and just put it. We can't have enough for sure. So we have our 3 bays, and they're all set up to have our hemo machines attached to them. Right now, we just have one intermittent machine that's currently in this hospital because we were in transition. When we moved, this room wasn't set up entirely, so we were actually still dialyzing the patient at our old hospital. So our other machine is getting moved over in the next week or so. So we'll have our 2 intermittent machines, And then kind of in our corner over here, we have the Revive system that we just got delivered to us earlier this week to play around with. We actually had a case we treated with that last night. And then we have our Optia, we have our Carpe Diem there. So I guess going
That's
along.
actually my machine, by the way.
Which one?
The one that got delivered to you is my machine.
I heard we get to keep it forever. You never get it back. That's
Huh.
that's the real reason he wanted to see this room, to confirm his machine was there.
keeping up on it. So I guess for just a flow, if we're kind of talking about that. So the way that we set it up is that we would have monitoring above each of the 3 stations. And again, we're still kind of building and setting everything up, so it's not finalized. And our idea is we want to get all this stuff behind the cabinets, really get it so the room looks really nice. We're just still organizing things. And as we're doing treatments, we're realizing how what we thought was a great way to organize the room is not. So we're now we have to live in it and actually understand how things are working. We have computers at every station, and then we also have on the other side of the room additional storage, another computer. We have kind of our lab area over there as well too. Although I'm sad to report that our ACT2 died during the move, so our workhorse of our ACT is now no longer functional, and so I have to get a new one, and I do not see any of the ACT2 on eBay, so it looks like we are going to upgrade to the ACT Plus. But it's been fun not having.
Still available? I'm not sure it's still available, is it?
Well, I found a used one of that, so that's what I'm getting now.
Okay. So it's a used one, not a new one.
Yeah,
Yeah,
used.
that was the route. I had to go that route as well for the ACT Plus on the secondhand refurbished market.
Yeah, that's how we're getting it. Yeah, so the room we're next to our ICU. If you kind of see the people walking by, it is the next room over is kind of our general triage area, and then the room adjacent to that is the ICU. So we're really close. We're on the first floor of the hospital to patients so that we can be close to ICU, but we are our own separate room. There's nothing else that's here, and no one should be in here unless they're us. So we're pretty psyched for it. It is a bit bigger than our last space. It's not as big as I would love it to be, but it is still it's still a great space to have. We do have on top of every station, we have an operating light so that we can have good light when we're placing catheters. We didn't have that in our last hospital, and we had to have like a light on wheels, which worked fine, but it just takes up space. So we made sure we designed so that each one of our stations, we would have a light, surgical light above, and then that's where we also have our oxygen connections, because that made the most sense for the room. I guess I'll take a second just to show you our connections for our water, because that's kind of the big thing that everyone worries about. But we have our RO machine actually across the hall, and this big black hose is the hose providing the feed water from the RO. And that hose actually is a closed circuit. So when we're not drawing water, the water that's being made gets sent back. And even when we are drawing water, if it's producing more than what we're taking, it draws it back and it puts it back into the RO system. So it helps minimize the amount of water that we use, but it also allows for disinfection. That whole hose will be heat disinfected from the machine. So then we have a connection with this gray hose, which again, we're still in the process of trying to change and clean up a little bit. But this hose then runs down to each of our 3 tables. So we have connections on the front of each of those tables. They all tee onto the hose. So then the one thing that we still have to create is just a disinfection point here that we can use to put in a disinfectant solution so that we can disinfect the lines going to the machines. But we have the RO actually kind of across the hall. It's probably a good like 30 feet away. So you can really, you can get some good distance between the RO and your room. And the RO that we got is the one from Fresenius, which is, I've been really, really happy with it. It's very quiet. It obviously doesn't matter much because we don't have it in the room, but it can produce a lot of water. It does automated heat disinfection. It's pretty fantastic. So it's a big upgrade from the one that we had been using for the last 8 years.
JD, that must be special tubing because you need special PVC for running RO to a dialysis machine. So this flexible tubing must be some special tubing, I suspect.
Yeah, you need to make sure it's up to specs because otherwise it can have substances that can essentially leach out. So you need to make sure that it is. And our plumbers talk to the dialysis unit plumbers to make sure that everything was okay. So we've checked on that. And then even the connections, you have to be leery of some of the connections in the circuit as well too. If they're going to put like a brass coupler or something on here, well, that's going to be bad because it could leach. So you need to make sure that all of the connections the whole way through are the appropriate tubing. So it was some effort to make sure everyone knew that we needed special stuff, but in the end, everything really got set up the way that we wanted it to. So pretty happy with it and excited to kind of grow into it a bit more. And we also have this huge thing. Look at this guy, this huge flat screen TV up there. So, I mean, I can do it.
He's always watching you, isn't he?
Yeah, exactly.
Well, but I've really advocated as well, and JD has set it up nicely. If you're going to build a dialysis unit, you ought to put in you ought to get a camera that you can do just what he's doing here, because sometimes you want to get a consult. You have a patient you want to get a consult with, and today, whoever you're consulting with could be right in your room helping you out. And it really, I would advocate that you put a big video system like that in your dialysis unit. Then you can attend rounds, you can present at rounds, but it's really helpful, if you need some help.
And so we have 2 cameras. We just haven't had them installed yet because it's obviously a pain in the butt to do. But we're going to put one camera, and they're both pan, tilt, zoom cameras. So we're going to put one here so we can get a good view of the room, and we can move that around. And then the second one we're actually going to put over here so we can just get basically a 90-degree perspective on the room. And we're going to hook them up to 2 different computers so that we could essentially, if we're doing rounds or something, we could log on with 2 different computers and provide multiple views simultaneously. So that's our plan as we continue to just get these things set up into place and where they need to be.
Great. Looks nice.
Yeah, I'm really happy with it. It'll be better as we continue to get all the pieces together. But for now, it's a great start.
Well, really, thank you for sharing that. Well, what do we have? 2 minutes left. 2 minutes for questions. Oh, there you go.
My first grade scribble doesn't quite do it justice the way your slide does, but you hit on this earlier, and I think this was a really important part of the conversation around using red cells as replacement volume in TPE or plasmapheresis, plasma exchange. As you said, when you give a transfusion, you're going to add to the total blood volume in the intravascular space, and that can lead to complications of volume overload. And if you, again, when you show your slide next time, it'll put my drawing to shame here. But when you take that fraction of plasma out in plasma exchange and replace it with red blood cells, you're adding more red cells for oxygen carrying capacity without adding to the total blood volume, and thereby avoiding hypervolemia, while at the same time getting a bigger jump in your hematocrit compared to when you add cells to the existing plasma fraction.
Thank you. That's great.
Can I ask a question?
Yeah.
I've heard a lot about the need to buffer blood when you give a blood prime. I just wasn't sure kind of how you do that or with what Is this one from?
Yeah, we do that on dialysis, and that would be a reasonable, well, if you're set up for TPE, you probably can't do that. But if you're doing a blood prime for dialysis, then we often will dialyze that blood for 10 or 15 minutes. And it's particularly important if you're using certain membranes. There's an AN69 membrane that's part of I think it's the AM60 on the Fresenius package is an AM69 membrane. That membrane is also in some of their other products, but the AM60 is probably the circuit that we would most commonly use that on in veterinary medicine that has the AN69 membrane. And if the blood gets too acidic, it'll release bradykinins. And so we usually dialyze the blood prime for a few minutes to get the pH stabilized, to remove a lot of other garbage that happens when those cells are just sitting, and that provides a more stable product. You probably won't be able to do that if you're doing a blood prime for plasma exchange, except the membrane is not an AN69 membrane, so you don't have the big concern about activating the kinins and getting these hypotensive reactions that you can get with a membrane that you would use for dialysis. Did that answer your question?
Yes, thank you.
Welcome. Well, I've got to jump to another meeting, so I'm going to bid you all a great weekend. Thanks, everybody, for your comments, and Jack for starting the conversation. That was really helpful. And JD for sharing your new beautiful unit. And we'll see you guys in a couple of weeks.
Thanks.
Thank you.